Hi, my name is Olumide Akinwale, and this is Nursing 431 Clinical Practice Podcast. I'll be talking about directly observed therapy, the dilemma. Thank you for answering the questions I sent out. Nobody got the name of the medication administration method for tuberculosis, and that's what you can see out up here, directly observed therapy. Um, with this podcast, I'm open to showcase understanding of this community health nursing practice topic. I am hoping to give a strong theoretical and practical foundation that can guide our future practice in community health nursing. I'm hoping to use this opportunity to demonstrate the ability to apply theory to practice and to share some ideas with you. And finally, I'm hoping to create an arena for reflection, future discussion, and some feedback from you. So I will start by looking at tuberculosis. Why am I even talking about tuberculosis at all? And then I'll give you some key facts about tuberculosis around the world, key facts on tuberculosis in Canada. We'll discuss treatments, historical landmarks, and then current treatment options. And then I'll zero in on directly observed therapy. What is it? Why is there a dilemma around DOT? And then we'll look forward. What can we do um, as an alternative to directly observed therapy in the future? These are the things I'm going to walk you through. So, why tuberculosis? Tuberculosis is a serious public health problem. It is the leading cause of death among people living with HIV. Now, why do I bring HIV into this and why is this important? Look at the statistics. In 2018, a total of 2,561 HIV diagnoses were reported in Canada, and that was an increase of 8.2% compared with 2017. What's worse, the national diagnosis rate increased to 6.9 per 100,000 population in 2018 compared with only 6.5 in 2017. And our province, Saskatchewan, reported the highest provincial diagnosis rate at 14.9 per 100,000 population. So, with this kind of statistics, TB certainly deserves considerable attention within the province. Also important is the knowledge that when infected with Mycobacterium tuberculosis, that's the bacteria that causes tuberculosis, most people develop latent TB. That is, the person's immune system contains the bacteria and they do not develop symptoms. However, in about 10% of people, latent TB progresses to active TB over the course of their lifetime. So that means in addition to the figures I've given you about active TB, there are 10% more people who are likely to join that statistics. Now, according to the World Health Organization in 2020, TB is one of the top 10 causes of death worldwide. That's alarming, right? It is also the leading cause of death from a single infectious agent, and it's above HIV on that list. So now, this is where it gets really interesting. Out of the 30 high TB burden countries that accounted for 87% of new TB cases, 8 countries accounted for 2/3 of the total, just 8 countries. And those 8 countries are India, Indonesia, China, the Philippines, Pakistan, Nigeria, where I come from, Bangladesh, and South Africa. Now, look at the next slide. 5 out of these 8 countries are on the list of top 10 countries migrating to Canada. So you see the red bars on the charts below. It indicates countries from which Canada gets the highest number of immigrants. So in 2019, the highest number of immigrants came from India, the second highest came from China, and then the Philippines, and then Nigeria. And these are the same countries that are also represented on the list of countries with a high TB burden. So this is the reason why it's important to be talking about tuberculosis, and especially in a place like Saskatchewan, where we have the highest rates of HIV in Canada, and with the knowledge that TB contributes to early deaths of people who suffer or who live with HIV. So this is what I'm talking about TB, its treatment, our opinions on the mode of medication administration, and how community health nurses can help patients cope with the dilemma of directly observed therapy. Okay, let's talk about key facts in Canada. According to the government of Canada in 2019, there were 1,796 cases of active tuberculosis reported in 2017. And that happened within two populations: foreign born individuals, people like me who were born abroad and migrated here, and then Canadian born indigenous people. These are the two groups of people that accounted for most cases. If you look at the chart on the right hand side, foreign born people alone accounted for 71.8% of people who presented with active tuberculosis cases. And then 17.4% was among Canadian born indigenous people. However, the rate of active tuberculosis in Canada was 4.9 per 100,000 population, with the rate highest among Canadian-born indigenous people. That means even the foreign-born nationals are those who have the highest number of tuberculosis. If you compare the number of cases with the total number of foreign-born nationals, it is still less than the total number of cases among the indigenous people. So in comparison with the population of the indigenous people still have a higher rate of tuberculosis. Now, these are the people that we see in the schools, we see in the communities. These are a lot of people that will present to us, in our hospitals when we start our practice. And so it's important to begin to understand that this is not gone. This, occurs among them, and we should start preparing ourselves. Now, but I thought, so when I mentioned that I was working on tuberculosis, the first comment I got from a colleague was, I thought TB has been eradicated. In the real sense, no, TB has not been eradicated. Now, the common misconception that TB may have been eradicated stems from the various major historical landmarks of tuberculosis therapy. So many things have happened to TB medication administration and treatment in the past, and they have been so hugely successful that people actually thought that it's been eradicated. No, it's not been eradicated. In 1944, there was a discovery of effective medications for TB. That's streptomycin and para-aminosalicylate acid. Now, in 1952, there was a revelation of triple therapy. There was streptomycin, there was para-aminosalicylate acid, and there was a very popular one now, isoniazid. That was in 1952. And then in 1970, we realized that isoniazid with rifampin could reduce the duration of treatment from 18 to 9 months. And what's better? In the 1980s, with the addition of pyrazinamide to these drugs, treatment duration reduced from 18 months to 9 months and then to 6 months. So these are the various historical landmarks with tuberculosis that gives us the impression tuberculosis problem has been solved, it's been eradicated. No, it has not been eradicated. It is still very much among us, and Canada in particular keeps getting it in from the various other countries that Canada is open to helping, hoping to getting their professionals in and so on. So what's the current treatment for tuberculosis? The most common treatment right now for active TB is isoniazid, INH, in combination with 3 other drugs. That's rifampin, pyrazinamide, and ethambutol. So with these 3 in combination with isoniazid, tuberculosis can actually be cured. Patients begin to feel better within a few weeks of starting these drugs. Now, how are these drugs administered? And this informs the reason for my podcast today. How are these drugs administered? Is it directly observed therapy? Among those who answered the questions I sent out, nobody got it. But it's fine. I didn't want you to Google. I didn't allow you to Google. Now, Directly observed therapy that a trained health means that a trained healthcare worker, usually it's a community health nurse or other designated individual, but it has to exclude a family member. A family member cannot do this. Will provide the prescribed TB drugs and will watch the patient swallow every dose. That is how tuberculosis medications are administered in Canada right now. So this is the method of administration of TB approved by the World Health Organization. So like I said, DOT means that a trained care worker, a community nurse usually, or other designated individual will provide the drugs and watch the patient swallow every dose. It is an attempt to improve adherence by active monitoring and recording of the consumption of each drug dose. Now, I have witnessed this happen with an immigrant who wanted to work here as a personal care aide and was told to go for the tuberculin skin test. You know what the tuberculin skin test is? That's a test conducted to check if an individual has been exposed to the Mycobacterium tuberculosis bacteria. Now, latent TB was discovered in these immigrants. That means this immigrant was not showing any symptoms, but because it was latent, it's there, she was placed on the 6-month drug therapy. So every Monday, a community health nurse knocked at her door, placed the medications in her hands, and ensured that she took it in her presence before she left. So that is directly observed therapy. Now, the dilemma is this. We have arguments both for and against directly observed therapy. There are people who like it and who feel it's proper, and those are the proponents of DOT. There are people who say, well, yeah, it's okay. However, this is what it costs the patient. Those are opponents of DOT. Now, what are proponents of DOT saying? Proponents of DOT are saying it helps patients finish TB therapy as quickly as possible without unnecessary gaps. And that's true. That's what DOT does. With DOT, the patient is able to finish it quickly. There are no gaps because someone is there all the time to make sure that this person takes it. It helps prevent TB from spreading to others. And trust me, TB is a very highly contagious disease. It decreases the risk of drug resistance resulting from erratic or incomplete treatment. So most times when we place drugs in the hands of patients and we ask them to take it home, they're not compliant enough. So they take it erratically, take it today, forget it tomorrow, take it the day after. And then eventually it leads to drug resistance. So what DOT does, according to the proponents of DOT, is it decreases the risk of drug resistance resulting from erratic or incomplete treatment. What more, it decreases the chances of treatment failure and eventual relapse. So these are the arguments from proponents of DOT. What are opponents of DOT? Opponents feel, people who argue against it feel, that it's a coercive model which leaves the patient as a passive recipient of therapy. And what it does is to erode the gains made in involving patients in the management of their own health. It takes us forever to build the trust with them. It takes us forever to get them to realize that they need to also be involved in the management of their own health, that's health promotion. And then we do things to them that erode, those gains. Some say it's also, conflicts with patient autonomy. It's in conflict with patients' dignity. It's in conflict with patients' integrity. Patients often feel they are deprived of their autonomy and lack the opportunity to influence the delivery of their own health care. In some cases, it's very difficult to reconcile patients working hours with supervision. I remember this immigrant that I witnessed several times. She had to call to say, oh, I am at this other place today. I am not at home. Please, can you bring the drug here? And other times she's like, please don't bring it to my office. I don't want people to know I am treating this. Please bring it home. So it's difficult to reconcile patients working hours sometimes with it. And of course, in-person DOT can also be time consuming. It can be costly to administer, especially in rural communities, where a healthcare worker may have to travel a significant distance for home visits. So these are some of the arguments that opponents of the DOT have about DOT. Well, what's my opinion about it? Am I a proponent or am an opponent? Well, I believe in the harm principle. The harm principle says people should be free to act however they wish, unless their actions cause harm to somebody else. So, yeah, you can choose not to treat it. You can decide because it's infringing on your privacy and your confidentiality. You don't want to go. That's fine. However, you have TB and it's highly infectious. And if we do not treat it, you're going to infect members of your family, you're going to infect people at work, you're going to be a danger to your community. So the harm principle says if you're going to be a danger to someone else, then we're going to have to get you to listen to us. And I'm a firm believer in the harm principle, which we have just learned in this course. And so I am more of a proponent than an opponent. I also believe in the ethical principles of ensuring the common good and balancing benefits with burdens. While there may be burdens associated with DOT, the benefits far outweigh the burdens. And so I am more of a proponent. What's your opinion? Are you a proponent of directly observed therapy or an opponent? Where patients reject the approach, how do you help them to come around? How do you build trust again and save the gains made, in involving patients in the management of their own health? These are a few things for you to reflect on. And as you reflect, looking ahead, let's talk about the future. What are a few other things people are beginning to do to supplement or complement directly observed therapy? There is wirelessly observed therapy. This is quite expensive. It's high tech, but it works. So wirelessly observed therapy is a novel patient self-management system. It consists of an edible ingestion sensor. So that means on each tab there is a sensor and it's edible. And then there is an external wearable patch. And then there is a paired mobile device that can detect and digitally record medication ingestions. So it gets sent to your mobile phone. Your mobile phone records it to a server, and then your physician is able to see, oh, well, yeah, he's taking the medications today. So in terms of accuracy, WOT is known to be equivalent to DOT and was even superior to DOT in supporting confirmed daily adherence to TB medications. It was overwhelmingly preferred by participants. But there is even something simpler than a wirelessly observed therapy, because in this case, you still get to use a sensor, you still need a mobile device, you still need to communicate with the server. Video directly observed therapy, simple VDOT. It involves the use of telemedicine to provide an effective means to monitor patient adherence to TB treatment regimes. So, results from pilot programs suggest that VDOT is a patient-centered, cost-effective, and reliable method of ensuring treatment compliance. So, this has been tried out in the US. It involves healthcare providers observing patients take their TB medications remotely via webcam, tablet, video phone, smartphone, whatever. And then it allows monitoring of medication via video without the routine in-person visits from public health providers. And just like I said, results are very promising and people have shown a high level of satisfaction. So in this case, your privacy is protected. Your privacy is not infringed upon, your confidentiality is not compromised. You take it in the comfort of your home, but someone has to be there to observe you when you want to take it. It takes just a minute and it's fine. So, in conclusion, tuberculosis is a serious public health problem. It is even more serious in Saskatchewan, where the rate of HIV is concerning. It can be treated, it can be cured, but it requires a rigorous medication regime that thrives on strict compliance. The best way to ensure compliance available to us right now is the directly observed therapy. Now, there are lots of arguments for and against DOT, but there are alternatives. There is the WOT and there is the VOT. This is the podcast on directly observed therapy, the dilemma. Thanks so much for listening.